Welcome to Back from the Abyss. I'm Dr. Craig Heacock. Sometimes in the course of psychotherapy, there can come a point where the therapist says something so real, so raw, so deeply true, so unexpected, and soul-stirring that the client, the patient, just begins to pour tears. Their face twitches. They find themselves kind of struggling to breathe. And it's the most powerful thing to witness or to experience it. I've been on both sides. And to experience is to feel so known, so heard, and so surprised. Because again, what I think brings forth these tears is when the therapist is able to point out something that the patient or client didn't fully see themselves. And this actually happened to me a few weeks ago. I was reading an iTunes review, of all things, of Back from the Abyss. And let me read it. But the effect was, and again, whoever wrote this, thank you so much. It was, well, you'll hear what happened. So I read this and I just started crying. I just cried and cried. And then I read it a few minutes later to my wife and I cried. And I read it to my mom and I cried. And it was because it was so true and unexpected. And it was just like what happens in therapy, I think, when you have somebody point something out that you didn't really know, but so true. So here's what it says. This is a review from December 6, 2021. Dr. Heacock's work on Back from the Abyss captures something that I've never been able to articulate in a succinct or concise way, which is everything I love about psychiatry and why. For those of us who have dedicated our lives to this field, a field that is so often misunderstood, dismissed, undervalued, this podcast is a love letter to it. That's where I started to cry. And Dr. Heacock infuses each episode with sentiments I've long held of passion, fascination, and appreciation. Yes, it's so true. I'd never thought of Back from the Abyss as a love letter. I've joked that it's my garage band and been more accurate that it's my passion project, but it is a love letter. Whoever wrote this, you are so right on. This is a love letter to psychiatry with all its warts and faults and problems and the people who've been harmed by psychiatry, but it's a love letter to psychiatry. This podcast is a love letter to my past, current, and future patients. And it's a love letter to all of you who listen, some of whom I've heard from by email or text or even on the video calls I did last year. And all those I'll never meet, but I do feel like there's this really profound connection that we have, whether you're in Adelaide, Australia, or Decatur, Georgia, or Fort Collins. So thank you so much, writer. This, you hit me right in the heart with that. And this is a garage band and it's a passion project, but I think mostly it's a love letter for all of you. Okay, let me pull myself together. In today's episode, I sit down with my number one go-to psychiatrist for second opinions on difficult cases. Psychiatry can feel so isolating. In my private practice, it's totally easy to go weeks or even months without having any direct contact with another psychiatric colleague. I remember hearing from various attendings during my medical training that knowing what you don't know and knowing when to ask for help are two of the most critical qualities of a competent physician. And I've been so fortunate to have Dr. Dan Fisher as a consultant and friend over the years to help me when I didn't know what to do. Dan co-founded the Guerra Fisher Institute in Boulder, which has been Colorado's preeminent ECT center for many years. In addition to being an expert on ECT, Dan consults on difficult cases of treatment-resistant depression for psychiatrists all over Colorado. In this episode, Dan and I explore the complex and ambiguous nature of treatment-resistant depression, and then we move on to discuss the relative merits and risks of ECT, electroconvulsive therapy, versus ketamine, versus TMS, transcranial magnetic stimulation. And finally, we touch on a new improved version of TMS called SNT, or Stanford Neuromodulation Therapy, which could turn out to be a much more efficacious version of TMS. One of the things I love about making this podcast is, well, number one, I've gotten to highlight some of the amazing stories of some of the patients I've worked with for years. And number two, it's been so fun to make episodes with some of my favorite clinicians in Colorado and people who I've collaborated with, people who I look up to, people who really changed my practice. And in season one, I did an episode with Amy Indermeal, my go-to OCD expert. I've done episodes with Saj Razvi, my trauma expert. And today, I drove down to Boulder to see my number one go-to psychiatrist consult guy. Every doc needs at least one or two go-to people to get, a second opinion. I love a good second opinion. It's so hard to find one. I've sent patients other places for second opinions, and so often I'm disappointed. And when I've sent patients over the years to my guest today, Dr. Dan Fisher, not only does Dan always call me with a really detailed, well thought out synthesis, but I get these amazing notes, multi-page, very well thought out notes. And it's such a gift because, as a psychiatrist, it's already a pretty isolating thing to do. And when we're struggling with someone and we need help and we don't know where to go, just to know that Dan's down the road in Boulder and can help me out, that's just amazing things. So, Dan, it's good to be here.
Thanks so much, Craig.
Yeah.
That was an amazing introduction. Thank you so much for that.
Yeah, you're welcome.
It's been great to collaborate with you, for sure, as well.
Yeah. So I thought maybe we'd just start off with this whole idea of what is treatment-resistant depression, treatment-resistant mood disorder. How do you think about that, particularly as a psychiatrist that people come to for second or third opinions, kind of the last stop. I think of Guerra Fisher and you as a place where people come where they're desperate, where they're not getting help anywhere else.
Sure. Well, let's start, because you and I have talked about this sort of stuff a lot, is even what is the definition of depression itself? Then we'll get to treatment-resistant depression, but depression is such a heterogeneous entity. A lot of what psychiatrists do, and part of the interest in what we do, and maybe arguably the fun of it, is trying to tease apart what the nature of depression is. In a strict research term, the idea of treatment-resistant depression, as you know, is failing. It's very reductionistic. It's failing two trials, adequate trials of antidepressant medications. That renders you, quote, treatment-resistant. And it's kind of a pretty horrible reductionistic definition if you think about it, because once again we want to approach that question of what's going on with this patient in not such a simple way, like, well, he's failed two trials of med, so do I do a third, a fourth, a 10th? Do I do ketamine now? Do I send them to some form of psychotherapy?
Or even that definition, Dan, two adequate trials of antidepressants. What's an adequate trial? And what does that mean? And number two, so many meds that we call antidepressants are not. I've talked a lot on this podcast how I think SSRIs are not, in fact, antidepressants for most people. They're anti-neuroticism, they're anti-obsessional, anti-ruminative meds, which can help depression kind of secondarily by dialing down those systems, but they're not bona fide antidepressants, I would argue.
Sure. And once again, from a research point of view, it's going to be antidepressants, almost regardless of what that varied cause or etiology is the word we use for the depression. So even if it's bipolar depression, some people probably make it into these studies with an undiagnosed or heretofore undiagnosed bipolar disorder, and they failed Prozac and then maybe Zoloft. An adequate trial would be based on adequate dose for at least, let's say, 6 or 8 weeks on that medicine. But, that would be considered a treatment resistance right there, just plain and simple. So again, we like to go, you and I and most of our colleagues like to go a little bit deeper into what it could mean, and maybe even use a little bit of an algorithm trying to find the sort of the root cause of why an individual patient who's not a statistic in a research study is not responding. So examples might be we want to rule out the big things like, is there a substance abuse problem that's actually co-occurring with their depression and maybe ultimately the main cause of it, like smoking an eighth of an ounce of marijuana every day or drinking a quart of vodka. That will certainly make you look very depressed. We want to rule that out. We want to rule medical issues out like sleep apnea or hypothyroidism or B12 deficiency. We will want people to go through a decent medical workup looking for those really common things that can exist and can mimic or worsen depression. Then there's psychiatric comorbidities, stuff that you are much more expert than I about, like PTSD, trauma history. Axis 2 pathology is a fancy word for, personality disorders. Could that be playing a role in a person's depression? And then within the realm of psychiatry or psychiatric diagnoses, there's psychotic type depressions, which are treated. It's probably a qualitatively different animal, different disease. And probably the biggest one for me, and I wonder if this is big in your practice as well, is ruling out whether the person maybe has not been diagnosed yet, but actually has a bipolar spectrum disorder. And sometimes, we have a way to diagnose that that's sort of, according to our diagnostic manual, which is a Bible of sorts that changes every 10 years, which is sort of interesting itself. But we have one criterion, which is you have had to have gone through a manic or low-grade manic episode to be bipolar. But that's probably the tip of the iceberg of people we might consider bipolar. There's a lot that haven't quite had that experience. They have a lot of depression, but there's then a lot of other variables we look for that make us say, you know what, I think this is a person I'd like to treat as if, quote unquote, as if they are bipolar. And that may be the reason they're treatment resistant, because they've been getting oodles of antidepressants for the last 10 years and never really a bona fide trial of mood stabilizing medications.
Mm-hmm. It's almost like going back to that definition of 2 med failures. It's almost, I'm thinking in my practice, whether people have 2 or 3 med failures or 25, for me, it almost always comes back to this question of trauma or substances. Because it seems like if you choose an adequate antidepressant, if you have 2 or 3 trials of a decent antidepressant, adequate trials, something's probably going to shift. But people come in these long lists. I've been on everything, and so when I hear I've been on everything, I think trauma.
Interesting.
And I think weed, cannabis, and I think personality. Something is some kind of self-defeating or borderline personality structure or something, because this whole idea of treatment-resistant depression is really, I like that you talk about sore throat. I think of it as like treatment-resistant leg pain. If you say, well, I have treatment-resistant leg pain and nothing works, well, it seems like question one is, what kind of leg pain are we talking about? Like, what is this treatment-resistant depression? It's this final common pathway. It's this very broad term, but it's so broad as to almost be meaningless. Yet we throw it around in psychiatry like it's a thing.
Right. And even the fact that you and I, who, we've both been doing this in the decades now, not in the months or years, might even have what they might call interrelator poor reliability. We might see the same person who, let's say, is treatment resistant, and you'll think weed and trauma, and I might go bipolar. So
I probably think that too. I mean, more and more, I don't think you and I have talked about this, but more and more I'm seeing that it seems like there's 2 buckets of depression. There's the huge bipolar spectrum, which is very large, and it's probably characterized by depression that tends towards seasonality, tends towards hypersomnia, tends towards early onset. And then there's everything else, which sometimes is called unipolar or major depression. But I'm wondering if it's more the non-bipolar depression is actually largely anxiety-fueled, neuroticism-fueled, trauma-fueled. It has its core in anxiety, because if you think about non-bipolar depression, I would argue, is classically characterized by insomnia. If you in the DSM, they talk about MDD, major depressive disorder, you can have insomnia or hypersomnia, which to me is like saying if you had a skin disorder, you can either have clear skin or cystic acne.
Right.
It presents
red lesions or brown lesions.
Yeah, so wait, how can major depression either have insomnia or hypersomnia? That makes no sense to me. I'm just thinking
I agree.
more.
It speaks to sort of that we are still arguably in an infancy in our field. Again, back to the sore throat, we have a way to know with a biomarker called a strep test whether you have strep, and then we have a intervention that has basically a virtually 100% success rate, and sadly we do not yet have anything close to that in our field. We have people who, at least like you and I, try to take some time to try to tease things apart, but until we have some more objective biomarkers or even psychomarkers, things that are sort of a test that has some great and well-established validity and reliability from clinician to clinician. Validity means it actually is testing what we call it. It's a real result, and reliability means that you and I both would come to the same conclusion. So we're not there yet, correct?
Right, correct, yeah. I'm wondering, let's just look at a general kind of presentation. So let's say when you get someone who has objectively severe depression, disabling, chronic, has had a number of what appear to be fairly adequate med trials, how do you, in general, think about is it time for electroconvulsive therapy or not? Because again, you are a go-to for that. But as I've also seen on your second evaluations, your second opinions, that you give a lot of thought to all the other options, what's been tried, what hasn't been tried. Mm-hmm. So when you kind of think about the typical patient who shows up clearly with severe disabling depression and has had a few med trials, how do you think ECT or not?
Right. Well, I'll back up again and say that would be the first order of business is to determine, in my opinion, whether maybe this is a heretofore undiagnosed bipolar illness. And in somebody who maybe, again, for a decade has been only on antidepressants. Again, it's like the sore throat where only they've gotten Tylenol and ibuprofen, and then somebody finally comes along and does a rapid strep test and finally treats it properly. So I wouldn't necessarily go to ECT in such a patient. I've had maybe 20% of the people I see, I feel that there's something like that's sufficiently untested that it should be done first, as long as the acuity, how sick the patient is not so horrible that we need to act sooner than later. So I want to rule out whether there's the bipolar possibility, and it's, again, just a rule out. It's often just sadly, an educated guess at best, based on a number of factors that you alluded to already. And then, of course, also looking for maybe a not so obvious psychotic depression, because that often needs a different form of treatment. But beyond that, it boils down to how sick are they? At the time I'm seeing them. Invariably, they will have been sent by some thoughtful clinician like yourself who has gone through a great assessment, given them different trials of different types of medications, sent them to different types of therapies, and they're still suffering. And so it's a matter of knowing and being able to explain to that person what is the statistical likelihood that next medicine trial, if they left my office and did one, would have of working versus ECT. And thankfully, there's still a tool, old and ill-reputed as it might be, with ECT, where the answer is almost always it's a much better chance coming out of ECT that you're going to get what you need out of it. And unfortunately, with more than a few medication failures, we now know from the STAR-D study that the chances of getting remission from that, let's say that fourth med trial, is something in the range of 13%. So that sort of data helps me inform patients. Yeah, you could try, 4, 5, 6 more trials and you will probably get it right, but it may take a year. And ECT might have 50 or 60% remission rate for what you have. And so that could get done within 2 to 6 weeks.
Yeah. I just want to step back to that idea of psychotic depression. I would argue that severe depression is delusional, like in an existential way. I'm a burden. My family would be better off without me. My children don't need me. I'm a worthless, piece of shit. I should have never been born. Like, I'm a stain upon the earth. I mean, just these shame and really delusional. I mean, not delusional in the way I think psychiatrists usually think of delusional, but some listeners might find it helpful just to have you kind of differentiate what you're talking about when you say psychotic depression versus what I'm talking about,
right.
Kind of this.
Well, actually, I really like that you brought up those things because my threshold, and maybe you know this about me, my threshold for calling somebody possibly bipolar is pretty low compared to maybe some other clinicians. Likewise, I'm like you, I see psychosis maybe where others don't because it doesn't have to be the more textbook, flagrant examples. But I'll share a great story of someone from my training that was the more flagrant example. It was somebody with a classic, we call it a mood congruent, somatic, bodily, in other words, delusion. This woman who was constipated, which happens to be a physiologic response to severe biologically based depression. She was constipated and therefore made the conclusion that her feces was there in her body, but it wasn't coming out the normal way. It was coming out from her pores of her skin. And she was convinced that she saw it and smelled it. And you could not divorce her from that belief. So that is the flagrant form of delusional material, let's say, that might render a patient an excellent candidate for ECT or maybe combinations of meds that involve antipsychotics with antidepressants. But I like your idea that the concept that there are these, that almost everybody with a real deep depression has, at the very least, I call it maybe the mountain out of a molehill phenomenon, which is a form of delusion. It's, I have a problem, a situational thing or a life issue, and I've now catastrophized it to the nth degree. That I actually would treat that patient as if they had a psychotic depression and maybe use the medications one would use for that or be a little quicker to go to ECT. You might see it differently, but I think even, I'm quick to put that person in that category and give the, quote, benefit of the doubt that maybe that's what's making this person not respond to the Prozac alone. Let's add some antipsychotic like Abilify or Risperdal to that Prozac. And if that doesn't work, maybe we'll try ECT.
Mm-hmm. In this huge bucket of treatment-resistant mood disorder, treatment-resistant depression, who do you see now in 2021 as the primary best candidates, the people that come in your office and you think, okay, ECT is what we should do, clearly?
Okay. I have an easy answer because it's people like you out there in the world that make the answer really easy, okay? I'll explain. Probably 9 out of 10 people that I see for an ECT consult will have tried, and I hand them a list of, here's like pretty much all the meds in the whole arsenal that we have in psychiatry, and it's amazing. People will literally have circled, 42 out of 57 meds or more. So we know they've done that. They've done CBT, DBT, all these psychotherapies. They've done that. And you have done ketamine, or Dr. Sugarman or Suddath and Boulder have done TMS. 9 out of 10 have done at least the meds with either ketamine and or TMS. So in a sense, that makes my job a little easier at times because we really are and people sort of fear this about ECT, but that really is when it's arguably the last resort in a sense.
Up until 4 years ago when I started doing ketamine, I sent a lot more people your way. I probably
That's true.
sent, I don't know, a handful of people every year to you for ECT. And I would say, you got to see Dr. Fisher. But since I started doing ketamine 4 years ago, it's a much smaller number. I send maybe 1 or 2 people a year.
I just thought you didn't like me anymore.
No, I like you. So I'm wondering, are you seeing that either referral numbers are down, and or maybe if they're not down, the people that are coming are more likely to have tried ketamine as an intermediary before they come to ECT?
That's a great question, and the answer is that they have. Our volume has been down, and there's probably a medico-economic reason for that. I don't know if I should go into the economic. We do have more competitors in our midst. But I think the medicos part of it is what you're saying. There are now other viable options. And literally 10 years ago, or 5 years ago, it might have been that 9 out of 10 ECT consults I do would have tried TMS. And now we have ketamine in the mix. So again, 9 out of 10 will often have tried both of those things. So just, again, the statistical chance that one or the other of those things will have worked is now just that much greater.
Yeah.
So, and I'm happy for that. I'm not,
yeah.
I'm not wedded to continue to do ECT forever. So,
there's emerging data that ketamine is not as effective for geriatric patients. For patients over 70-ish, 75, that ketamine just doesn't seem to do. And I've seen that in my practice. I have a few people it's helped, but it just doesn't seem to have the same effect, but that
why
seems
do you
to be.
That is?
I don't. That's so. Maybe there's some sort of diminished BDNF burst, because ketamine really causes a huge BDNF cascade burst. Maybe ketamine also changes sleep architecture, so maybe that's less responsive in older folks. I have a personal theory that ketamine improves sort of glial cell metabolic waste dumping from the brain, and maybe just the brain doesn't work as well. And so kind of these, I think of ketamine as like compost for the brain, and maybe there's the geriatric brain just is kind of like old spent soil.
Right.
I mean, it's just
that's
like
a good point.
Whereas, I think of geriatric depression, that's a home run for ECT,
right?
Or at least
absolutely. And in fact, I was going to say that's where it actually, even non-psychotic depression in the elderly, it works better still than the same type of depression in a 32-year-old or a 25-year-old. And I can't explain that at all. I have no good explanation. 'Cause I think ketamine and ECT probably do have some common final pathway with that BDNF narrative that you just talked about, the brain-derived neurotrophic factor, like the fertilizer of the brain. ECT does that as well as ketamine, pumps that up. So who knows? I mean, but ECT, as they always say, it's sort of it's shotgun approach. It is so macroscopic. You're doing so many things to the brain. You're pushing on it in so many different ways that maybe for a geriatric depression patient, it's a completely different mechanism, but way above my pay grade to understand.
There's been some writings sort of theorizing that ketamine is kind of a chemical ECT. And I think even you saying like it's a big push on all the systems of the brain, electroconvulsive therapy, and ketamine is too. It's affecting many things. When you look at the recent review articles, how does ketamine work? They usually list 5 to 8 putative mechanisms.
Yep.
But I also think it's really interesting when people come in and ask me, what's going to be the scheduling for ketamine, the timing. I think a lot about ECT, and that it's like there's an acute phase where you're doing some number of treatments to get people well or in remission, and then for many people you're doing some number of treatments over increasing span of time to sort of keep people well. And then some people benefit from ongoing ECT maintenance or ketamine maintenance. So that makes me wonder if actually that metaphor, that thought that ketamine is chemical ECT, that there's something to that.
Sure.
Because they have a very similar pattern, the way they're used clinically.
Right. And I always, I'm waiting for that data to come out about ketamine or even TMS, because ECT finally, maybe in the last 10 or 15 years, has a decent set of data points for what we should do after that acute phase, that initial phase of 2 to 6 weeks to get somebody better. And interestingly, there's some studies now where they're comparing ketamine to ECT, randomizing people who are otherwise ECT candidates to one or the other, and doing a very similar acute treatment course followed by a maintenance treatment course, and following them for about 6 months. That's going to be really interesting to look at. But long before, even when TMS first came out, as an ECT provider, I was convinced that there's going to need to be some maintenance provision. It just makes, it's psychiatry 101, that you need to maintain that which has been proved to be helpful. And a lot of the TMS providers from 10 years ago somehow came up with this narrative that I've honestly found a little bit hard to believe, which is that there was a subset of patients who were kind of magically cured for good. And I think that's sort of not turned out to be so true. And nor will it be for ketamine, and nor is it for ECT. The relapse rates during the acute phase, during the maintenance phase, that 6-month period after the acute treatment, if you don't do maintenance medicine and or maintenance ECT, which is just some treatments to sort of boost the effect, the relapse rate's incredibly high. It's over 80%. So
another way that ketamine, I think, is a lot like ECT is that I remember when I was in residency, a big study came out. Actually, it was done from some people at Brown, where they looked at what happens to people who go into remission with ECT. One group goes off their meds and one group stays on their meds. And you know this data, but it showed that the people that go off their meds plummeted. Yeah, and that same thing with ketamine. So many people come to me for ketamine and they say, I want to do this ketamine treatment and this way I can get off my meds. And a few years ago when I started doing this, I thought, that'll be good. And now I've realized the vast majority of people are not going to get off most of their meds. And when we try to do that, especially if we try to get people off lamotrigine, sometimes we can get people off atypicals, but more often than not, it seems like the ketamine is kind of rebooting or juicing or composting the brain to help the meds work better, but it's typically not going to replace them. And that's what I kind of think of ECT the same way.
I'm curious. Tell me what you are doing, in your sort of heuristic approach, your sort of trial and error approach with it, because again, there isn't great data yet. What is the sort of spectrum that you see in that post-acute ketamine phase? How often are you doing ketamine treatments, and how does that vary from person to person?
Yeah, that's a great question. Well, unlike ECT, which has been around for decades, and I think the protocols are pretty well worked out. Like if you start doing ECT now, there's good data to guide you, whether you're doing unilateral, bilateral, how long the seizure needs to be, and how to think about seizure threshold. But with with ketamine, it's still some of the most important questions haven't been answered. So we know ketamine is super helpful for a lot of people, but what dose? What route, what frequency, do people need to have a fully dissociative psychedelic experience? This is all super controversial, and it's being studied now. But what I've seen in doing well over 2,000 treatments in the last few years is that the standard protocol of starting at 0.5 milligram per kilogram, that is a lot like, 200 milligram ibuprofen for a severe headache. Like it will help. It's not the same as 600 to 800 milligrams. It's not. And, I heard a podcast the other day where they said, the expert said, there's no dose response curve with ketamine. And I thought, that's insane. Now, this wasn't a doc who does ketamine. There's a huge dose response curve. So, what's the, what's the response and remission rate with ketamine? I think it so depends on what dose you're using. I usually start people kind of right at the edge of the psychedelic dissociative threshold, and the second treatment go to a fully immersive treatment. And typically people can be deeply catastrophically depressed, and within 2, usually maybe 3 treatments can go into remission. But if you look at the data, you talk to people who run the kind of low dose, high frequency ketamine clinics, they're starting with 6, and they're often doing a whole course of 6, 8, 10 more treatments over a month or 2, and they're getting pretty good results, but at much greater cost and
interesting
and effort for everybody.
So there's
involved.
A monetary incentive, arguably, to doing 200 milligrams of ibuprofen more frequently, and you're giving people, by analogy, 600 to 800, but only a couple of times maybe, and you're seeing some more robust response from that. Did you experiment initially with using the more sort of, let's call it studied or standard of care, 0.5 milligram per kilogram, and just come to your own conclusion that it just wasn't as impactful as when you would go up on that same individual even?
Yeah. Well, it did start low in the first year, but it was super interesting. So, some percentage of people that do ketamine find it very frightening. And I've had a number of patients over the years who had a frightening experience, and they said, okay, next time I want to go lower. I don't want it scary. I want it to be gentle. Like, okay, fine. So we drop it significantly, and then they're texting me or calling me 3 days later, like, I'm no better. And they're coming back saying, give me what you gave me before.
Frighten me.
No, right. And again, maybe it's like an active nocebo or whatever, like the scary experience is thinking, okay, this must be powerful medicine. We can't rule that out. But over and over, when people have had a subdissociative experience, or when we've lowered it significantly because of nausea or whatever, some untoward effect, almost invariably, the feedback I get is, that was a more gentle treatment, and it didn't work nearly as well.
Interesting.
I think that, I call the full deep dip, or, the fully immersive treatments, those are intense and can be a little overwhelming at times, but I'm seeing people get, lasting, sometimes many weeks or months of remission from those.
Interesting.
But I think a lot of the ketamine clinics where they're doing, high numbers, high volume, don't want to deal with that because, a lot of people have some intense kind of trauma catharsis, and, there can be sobbing and shrieking and crying, and, it can be psychologically really intense. We're trained to sit with people, and that doesn't scare us. I think maybe other specialties in medicine find it a little scary to sit with someone who's having a full-on kind of trauma catharsis as they're coming out of high-dose ketamine.
And what do you find sort of calms them or helps them get through that just in the moment?
Well, in the early days doing ketamine, I remember seeing people sometimes come out crying, sobbing, wailing, and I thought, oh no, bad trip or bad experience. But I started getting feedback, people saying, oh no, that was exactly what I needed. Because I was calling these people later in the day, are you okay? and inevitably they said, no, that was so good.
Wow.
I have a couple people with sexual trauma history that when they came out, they just vomited, even with Zofran or scopolamine on board. And again, they called me later in the day. They said, that was such a purge. It was what I needed. I was like purging out trauma, kind of spiritual metaphoric trauma. So it turns out that much like with other psychedelic works, sometimes the most painful looking experience from the clinicians, from the doc's perspective, when you hear the subjective report from people, they say, that was exactly what I needed.
Interesting.
Like that was just,
Well, and I was going to say there's clearly a similar kind of dose response curve with ECT, but the people are anesthetized, so they're not aware of it. So I can't attribute it to any sort of psychospiritual effect. But clearly, there is a dose response in terms of the electrical stimulus, the amount of electricity you use to invoke the seizure is part of the therapy, and having an adequately long and robust seizure is part of it. So, and we have that as true for medicines. 2 milligrams of Prozac isn't going to cut it for your anxiety disorder, but 20 might. So I'm not surprised by that, but it is amazing that that's not really, correct me if I'm wrong, well studied yet. The value of those higher doses, or you tell me if I'm wrong, the correlation between a subjective sense of improvement or objectively measured improvement and having had that greater dissociative effect, or having the higher doses do that.
Yeah, it's being studied now, but there's I've seen some little, 10-person pilot studies where we compared 0.75 with 0.5. So there are some really small studies, but
Gotcha.
But this, I think this important question, like, is a fully dissociative ketamine treatment, at the psychedelic level, is that in general significantly more effective treatment? I mean, that question has not been conclusively.
And
proven.
let me ask this to you. I mean, I use the term, I don't want to put words in your mouth, that it's based on some psychospiritual effect of the drug. You talk about patients, let's say with a trauma, who said, that's just what I needed. Do you think it is something psychologic or less effable, less describable in any biologic terms? Or do you think the higher dose does have some greater, maybe BDNF enhancing effects that leads to those downstream neuroplastic effects that we believe is part of what makes the ketamine and the ECT and TMS and medications successful? What's your theory there?
I think it's both. For years, I don't think I was taught this in residency, but for years when I've evaluated for trauma with people at initial appointment, I've used the word haunted. I think ever since residency, I say, are you haunted by, things that happened to you as a kid, or haunted by, sexual encounters, or does anything haunt you? And sometimes a lot of patients are like, why are you using that word? I said, well, I don't know, but that's what I mean. But a lot of people totally hone in on that. But, in recent years, as I've just learned a lot more about trauma and met some amazing people on this podcast and talk with trauma experts, I've really come to believe that that's actually a really accurate word, that trauma haunts us in this kind of psychospiritual way. What does that actually mean in the Western allopathic medical model? I don't know, but it is a psychospiritual haunting. And I do think the higher doses of ketamine, much like DMT with ayahuasca or psilocybin, I do think there is a psychospiritual effect. There's a BDNF effect. There's a sleep effect. There's a glutamate effect. But there's also this purging of trauma energy. But I don't know what that is, but you can see it when you sit with people and they describe it after they've gone through it.
People can't see me, but I'm smirking admiringly at you right now for the way you're talking about this, because it just, I think to myself, this is what makes our field both frustrating, but mostly incredibly interesting, that we don't really know this stuff yet, but there can be elements from the reductionistic model of how neurochemistry has changed, or brain structure, to something that you might call psycho or spiritual. So it's kind of cool, but good luck with us really ever figuring it all out,
It does. Yeah, I think psychiatry is the most interesting field of medicine.
No doubt.
Who do you think of as classic non-responders? Again, so you're seeing people come to you who have tried everything. And now, many have tried ketamine and meds and therapies and been to treatment centers, and they come for ECT. And are there characteristics of people, of patients, when they show up and you decide that they're going to do ECT that you think, this is not a hopeful prognosis?
Yeah, there is. And it's probably the same variables that would make it true for any somatic or biologically based treatment. And that would be somebody who comes in and literally says the words, let's say they're 25 years old, and I'm trying to get their depression history and discern whether there's been an episodic nature of it, which is much more classic for the biologically based depression, versus more of a chronic state. And they say something like, I've been depressed since I've been 4 years old, since I can remember having words to think about it. I thought about death when I was 6. And okay, Mr. Smith has that, you're 25. Have you gone through, I don't know, a few months here or there where you actually felt well? Oh, no. So that person, I hate to say it to them, but I do share that I have some worry about whether anything is going to alter something that is so entrenched. And again, what is that thing? Hard to know. Again, is there some temperamental or biologically based thing, or is it trauma? Of course, I asked more than a few questions in that direction, but presumably those same people will have been through years of good therapy as well and not responded to that. So that would be a patient that makes me nervous about anything really working. But in the service of knowing that this is somebody who honestly has no other alternatives. I mean, they have been through, I told you I give people a list of 50 plus meds in our armamentarium, and they've circled every one, and they've done the TMS and the ketamine and the different psychotherapies and the, supreme workup at a Mayo Clinic or something like that, looking for some strange, medical or whatever. And I still will do ECT on those people. And the happy news is, amazingly, there's a subset of them that actually do well. But I kind of forewarn them, as I have to forewarn myself going into it, that we're probably going to hit a ceiling of success. They're not going to be all of a sudden, become the cheerleader of the football team or something. Mm-hmm. Sort of like the analogy of, doctor, after you do this procedure, will I be able to play piano? And if the doctor says, yeah, of course. And, oh, good, I never played before, So.
Yeah. What's your threshold number of treatments of seizures that you think is worth trying before you decide this is just not, and let's say you're not seeing any improvement. I mean, do you do 5 electroconvulsive treatments? Do you do 10? I mean, what, and I'm sure it varies on the person and the age and how desperate they are. But what in your mind, when do you get to a point where, the chance of anything meaningful happening is really plunging?
Thankfully, again, there's some good guidance about almost like when there is, what's a minimal number of treatments whereby if you do less than that, even if somebody's doing really well, there's a really high risk of relapse, or conversely, diminished returns if you go beyond that other large number. And those numbers are probably about 6 to up to 20. And maybe if you look at arguably a normal curve, it might be more like 8 to 16. That's where the vast majority of people will fit into.
To start to respond.
Or to get their maximal response, usually by 16 for most people. But I will push it beyond that when, again, in a risk-benefit analysis, the alternative is nothing better because they've tried literally almost everything. And I have a great story about that. My mentor, Dr. Frank Guerra, who had been doing ECT for decades before me, and he and I shared a case maybe 15 years ago of an elderly woman that seemed like she had a severe depression, but it was near catatonic. Catatonia is where you're hardly moving, not eating, not drinking, not talking. It's almost like you're in a coma, but your eyes are open and you're otherwise actually kind of aware. People say after the fact they were aware. So she was in that state, and she had lost, 30 pounds over 6 months. And we were about, I don't know, maybe 14 treatments into this ECT, acute bilateral, the more robust form of it. And she was just not budging. And I think she was probably in her mid-60s, and, just on a pure chronology point of view, just based on her medical issues, this is somebody who could theoretically have 30 more years ahead of her. But the choice at that point, if we were to stop ECT, because she had tried truly everything else, was nursing home till she died, probably from inanition, fancy word for, not eating or drinking. So I discussed it with Dr. Guerra, and I was in this mode of, I really feel like we have to stop because I have done 15 or 16. And he said, the alternative is just simply much worse. And we did 2 or 3 more, and just by, it was a beautiful thing. There was like applause on the unit because 2 to 3 treatments more, she was up, feeding herself, talking. It was literally like a light switch went on. So I've always reminded myself of that, where it may feel like a lot of treatment, but when the chips are down and the alternative is, clearly much worse, we will go to 20 or even more sometimes. But truth be known, I think I've never really seen anybody need much more than 20. And if they haven't gotten better by then, when I have gone beyond that, it's pretty rare that they do.
Mm-hmm.
Yeah.
For years, I thought of 3 treatments in psychiatry as kind of the miracle triad, the top 3, the things that made psychiatry just completely thrilling at times. And in no particular order, those are ECT and clozapine and Suboxone, buprenorphine. And for a long time, I gave a couple talks on that. I remember at grand rounds, and just said, these are 3 treatments which can completely change, the course of an illness so fast in a way that seems almost miraculous. And lately, I'm adding ketamine to that list. And so this is a segue to thinking again more about ketamine and ECT, because I think you and I would probably both agree, at least as of now, 2021, for people that have failed a bunch of meds and failed therapies and psychotherapies, that really we're looking at the 2 best options is ECT and ketamine. And so when I think about risk and benefit of those, ECT is very safe, but it clearly has the short-term memory effects. But I have a number of patients who are absolutely insistent that they have long-term memory cognitive damage from ECT. So I don't know. A number of these were treatments done back in the 80s, or but I have a couple patients who had well over 100 ECT treatments, and so I'm wondering how you think about long-term cognitive and memory impairment. Is that related to number of treatments, to bilateral versus unilateral? Have protocols changed such that people getting ECT today are less likely to have that?
Wow. Is this the 5-hour podcast? Right. Because I think that's what we need for this.
I know this is a huge topic,
and it's the single most important or talked about topic in my consultations. I literally spend 3 hours for an ECT consultation, and probably it feels like to me 2 hours and 55 minutes of it are about cognitive side effects.
So if people listen in on your sessions, you're talking cognitive. People listen on my sessions, they're hearing me talk about weed and sleep. And I've told my kids before, I'm kind of a weed and sleep doctor, because it seems like I'm constantly talking to people about marijuana. But
sure,
go ahead.
Well, here's what I reduce it to people. So first of all, the biggest fear that people have, and it, maybe it's related to this patient you're describing or the couple of patients, is they fear that they've had brain damage. So that's one thing we could say with definitive certainty, is that there is zero brain damage from ECT. In fact, that brain-derived neurotrophic factor narrative is a great one to use for patients because ECT, like ketamine, increases BDNF. By so doing, it actually reverses cortical and hippocampal atrophy that comes with chronic and severe depression. It sort of revivifies the brain. ECT does that. The very thing that makes you have memory problems, at least for most people temporarily, is actually building back some important brain areas. And that's been shown as well. So I bring that up with patients because, again, I don't want them to leave with a sense that they're fading their loved one or themselves to brain damage from ECT. Now, that said, there is some cognitive side effects that are to be expected. And to further the analogy with the BDNF, you might say, well, how could you say on the one hand that you're doing a treatment that pumps up the brain, the hippocampus, the seat of learning and memory, and then it causes memory problems? The analogy I use, right or wrong, is what happens to you if you've never been to the gym or you haven't been to the gym for like 10 years and you go there and the first week or two you're doing bicep curls. At first, you have very, very painful biceps and they're kind of weak and they're not doing that well. But 2 or 3 weeks later, your bicep is big and strong and quite functional. So the fancy word is hormesis. You're sort of stressing the brain. You're stressing that bicep so that it grows later on. Anyway, I go on to that narrative because it's an important thing to sort of divorce people from that assumption that there's going to be brain damage. But what does happen during the treatment with almost certainty? The thing that happens with almost certainty is you will have short-term memory deficits during the 3-time-a-week phase, which is the inability to consolidate new memories. So let's say you go out to dinner after your 6th treatment of ECT, you go to the Red Lobster, and then the next morning your wife quizzes you and said, "What'd you have at dinner last night?" Conceivably, you may not remember even having gone to Red Lobster, let alone the fact that you got the shrimp scampi. So, that happens inevitably to some lesser or greater degree. But it's equally inevitable that within a month or two of your last acute ECT, the 3-time-a-weeker, that is back to normal, and often better than your baseline, because if this ended up working on your depression has huge cognitive impact, negative cognitive impact, and probably harkens back to that idea of the atrophied parts of the brain. So those people are often doing better memory-wise. Now, there's some people like you've described who, and I've had them for sure, and I've dealt with this question, who after a course of ECT, they usually will acknowledge that their short-term memory is better, but they might say, I've lost some chunks from the past. And it is not the norm, but I've heard it in a significant minority of patients. And I'm never really sure exactly how to explain it, but I'll share my experience with it. I have had the pleasure of knowing that to tell people you just need to do some reminiscence therapy. Go home, look at photo albums of that trip to Hawaii from 5 years ago that you no longer think you remember. Look at the pictures, talk to your spouse, be reminded of things you've done, and 9 out of 10 times, those things do come back.
Plus, that's a chance for the spouse to say, "Oh, it was such an amazing trip. It was so great when really there was a huge fight on the beach
right.
and talks of divorce." And
right.
you can say, "Oh, we had such a great time.
Precisely.
Look how happy we were."
That's right. And so, there is that retrograde amnesia for some people, but there's so many things beyond ECT that I think explains it. A big theme I talk a lot about is called state-dependent memory. I learned this in college in Psychology 101, where a professor said, if you study for an exam drunk, take the test a week later drunk, because you'll remember more when you're back in the same, quote, state, in this case, intoxicated. Well, I've seen that, I imagine you have too, with mood disorders. When you're in a depression, especially the deeper and the more psychotic and the more near catatonic it is, the more the following is true. When you get better, you just, that time frame in which you were depressed seems like a big blur. So that's called state-dependent memory. And so some people have been sick for years. So they may have some altered sense of recollection for that past from that phenomenon. And then back to the short-term memory problems from the acute ECT, I've had patients who have called me, and maybe you as well, 6 months after they should have been better from that. And maybe they had been better from that, but they say, okay, Dr. Heacock, my memory is bad again. This ECT has lasted so long at messing around my memory. Well, if they had gotten better, and almost invariably they would have, and now they're worse again, like 95% certainty they're depressed again. And that's the real explanation for the cognitive hiccups that they're now having, or maybe a new medication, or they're back on the bottle of vodka again, or something like that. So you don't recover from the short-term memory deficits during the acute phase, only then to have it come back like a virus that can repeat itself. It only gets better and stays better, and if it's not better, there's usually something else going on to explain it.
Another confounding variable I just thought of is, as I run through the people that I can think of in my practice who say they've had long-term memory or cognitive deficits, 4 that I just are thinking about off the top of my head also have big-time trauma history. So that's interesting thing about state-dependent, that, could it have been that they spent significant periods of their life, dissociated, and so not really taking anything in. And now that they're better, they look back and say, I don't remember my 20s. My 20s are mostly gone. And that's the fault of ECT, which may or may not be, but it also could be because they were so deeply in dissociative numbing for a decade that they really retain nothing.
And I don't like patient blaming. So what I'm about to say may sound like this, but there seems to be, you're spot on. The demographic of often trauma victims, maybe with sort of, very unstable bipolar disorder or maybe borderline personality, have the phenomenon of what you've just described most commonly. And the thing that also seems to go with it is they're the ones that are quite angry, even though if ECT arguably saved their lives, and many times it did, when they did it because they were in the throes of some suicidal deep depression, they are the ones most angry at me for now giving them this horrible brain damage, ...
Who could be angry at you? You're such a good guy.
Oh, let me welcome you to my practice for a few days.
And that's funny. The other day, my wife, who's a therapist, said, "Oh, it's such a hard session. This woman argued with me the whole session." I said, "That doesn't happen to you a lot?" She said, "No, people don't argue with me." I said, wow. I said, come to my world. I said, I have people arguing with me all the time about everything. So anyway.
Yes.
I wonder if I want to make sure we save a little time to talk about TMS. So just to review, I see, at least at this point here in 2021, that, for moderate to severe depression, after you've had med trials of adequate duration, of proper choice, and you're properly diagnosed, and you've had good psychotherapy, and you're not abusing substances, and, you've tried to get your ducks in order and you're not getting better, ketamine is probably your next best option, unless you're geriatric, unless you're actively substance abusing.
Psychotic, maybe.
Yeah, psychotic, yeah. And the ECT is still, again, I would put that in the four miracle treatments of psychiatry. But there's a whole issue of TMS, and you and I talked a little bit about this before the recording. And I like the idea of TMS, that you can just go and have these magnets put over your head and get zapped with magnets, and it seems so kind of Star Trek and like where we should be going, versus taking pills, which just dissolve and distribute through all your body compartments and fluids, or even ketamine, which is super cool treatment, but what's really the active part of ketamine? What's the special juice? But TMS seems like, wow, this could be the thing. But the data to date have not shown TMS to be very robust in terms of either response or remission rates. In fact, if we think of treatment-resistant depression, as you said, after a few med trials, you're like 10, 12, 13% chance of improving with a new med. And I think with TMS, it's not much higher.
Yeah. I just had reviewed some of that stuff, and I think if you had failed 3 med trials, again, one of the definitions of treatment resistance is at least 2, but in this case, 3 med trials, your remission rate with TMS in the conventional sense that it's been done, which is a 6-week course of treatment, was only 17%. And when you, like anything, when you use it in a population that are much less treatment resistant, those numbers look a lot better. So a lot of TMS practitioners they seem to parrot on this sort of third, and third. I've heard that so many times now. A third don't respond at all. A third at least have a response, which would be a 50% reduction in their depression rating scale. And a third remit, which is they're all better. And then again, there's this narrative that many of them just stay better with, magically. And it was hard for me to wrap my head around that. But if those numbers are valid, it's probably a less treatment-resistant cohort of patients that fell into that category. And that 17% remission rate, which is only, a few points better than yet another med trial per the STAR-D, is speaks to that. So, it would be, and maybe it's going to be a new and better thing with this new protocol they've come up with. So,
yeah, you sent me an article. I hadn't seen it on SNT, which is a new kind of hyper-energetic focused TMS protocol. Maybe you could just briefly describe what that is and what some of this preliminary data shows.
And again, full disclosure, I don't do TMS, so maybe we all have our biases, and but this looks really pretty promising, and maybe quantifiably quite a bit different, but small study, and I think 29 patients or something. And they basically did something called theta burst, which is the type of magnetic pulses that are given. They, instead of doing 1 3-minute treatment one time a day for 5 days a week times 6 weeks, they did pretty much in 5 days 5 times the amount of magnetic pulses. So you're basically in the clinic 10 hours a day for 5 days, and you're getting the equivalent of 10 treatments, and each treatment is 3 times longer than the typical ones they used to do. So it's a hugely, talk about dose response curve.
Yeah.
It's like all of a sudden, oh my God, we've discovered 2 milligrams of Prozac was not very effective, but when we tried 20, we got results, or the ketamine story that you give. So they've finally, maybe just increased the dose and then consolidated it in 5 days instead of 6 weeks. And then there's another attribute to this new treatment where they use a functional MRI to more precisely locate in the dorsolateral prefrontal cortex the area that, when it's stimulated by the magnet or the electrical field that is, or the electric stimulus that's imparted by the magnetic pulses, it reduces the activity in the anterior cingulate cortex, which is overactive in depression for many people. And so they really fine-tune the localization. I don't know if that's honestly where the money is, rather than the fact that they've much more than quadrupled the dose of the actual thing. But the results in this small study were very impressive, like 50% remission at the 4-week mark. So in other words, 4 weeks after that first week of treatment, 50% of people were remitted. And in the control group where they used a sham stimulus, it was something like 7% remission, or maybe even less than that. Maybe it was 0 even. So that's like that, the differential response between placebo TMS and real was pretty darn startling.
It's so interesting, though, that it may be that the main reason TMS hasn't worked very well is because it was just underdosed.
2 milligrams of Prozac.
Yeah.
Why isn't that working?
Yeah. But I wonder, maybe you have a sense of this, I don't know, the machine or the equipment that's needed to do, let's say, this SMT protocol, this theta burst. I mean, are those $1 million machines? Are those
Not my
Oh
understanding.
no, okay. I have no idea.
No, I think. Well, actually, I can't say for certain. To do the functional MRI, you need to have a center that can do that, and I think there's mostly academic centers that do that, and then there are some private centers that will do it, probably for a pretty penny. My guess is insurance will take a long time to come around paying for. And the machine, though, I think is the same machine that is in most communities right now. But once again, they're leaving it on for longer, effectively.
They're turning it up to 11
That's right.
instead of 2,
Exactly.
2.2. Yeah.
That's right.
Yeah.
So, I don't think there's anything special about the machine. And now, how much do they cost? I haven't looked into it for a while, but it might be in the realm of like an $80,000 machine, $90,000 machine maybe. And then you have to pay some yearly, like housekeeping fee. So they can come in and change the software and, brush it off for you, whatever.
Because, I don't know if you've had this. I've had at least 2 psychiatrists reach out to me in recent years saying, hey, Craig, you want to buy my TMS machine?
Oh, yeah. Yeah, that's a common one.
Which to me is not a winning endorsement of TMS.
Maybe they thought you were Craigslist.
Yeah. I'm imagining if I started calling my psychiatrist colleagues, hey, do you want to come? I got a bunch of IV bags and ketamine. You want to buy it? Actually, I could probably sell it. But,
Right.
But it seems like if this data holds up, that we may be coming to this interesting new world where for treatment-resistant depression, there's sort of a tripartite approach, again, with ECT as the last thing.
Sure.
Where we're looking at ketamine or, a high-intensity TMS with theta burst, and then psilocybin, because I think psilocybin is coming soon.
Right.
And there's some really exciting data about psilocybin with OCD, with dysthymia, with severe depression. I think what's super interesting about the psilocybin work is it looks a lot like ketamine in that people are doing intermittent treatments and getting, weeks to months of response. And from what I've seen, at least in some small trials, high-dose psilocybin, so the really intense experiences, which would be sort of like what I'm doing with ketamine in my clinic. Right. Some people are getting many months, like 6-8 months of remission from.
And that's so atypical for what we normally expect from our patients. And so, when anything that really does start to approximate a, quote, cure, it would be pretty amazing. And I think all of these things, if you don't disagree, will have a role, even ECT.
Oh, yeah.
ECT, there's going to be patients, just because, again, back to that sore throat analogy of what is depression, there's so many different sort of subtypes, even biologic subtypes, let alone, the psychospiritual subtypes, if you will, that there'll be a place for all of these things, and because they're all going to work differently enough. So,
could I point out 2 of them? And these are both ketamine people, and you may remember them. So in 2019, I sent you a woman, actually geriatric woman, who had tons of treatment, so much of meds, and she'd had ketamine, and she was basically catatonic, very vegetative, and it was a complete miracle. In fact, her family, after the treatment, they all gathered in my office and they sobbed. They hugged me and they sobbed and sobbed and sobbed and said, "You saved her life." I said, "I just got her to go see Dr. Fisher." They said, "Yeah, but you suggested it and you were the one that really convinced her." Because, of course, that's hard with ECT, because usually if people need ECT, it's hard to get them to consent because they're so
scared, brain damage.
Yeah. Well, they're just right. They're so brain damaged in their depression. But the second one was one, I think it was last year. A guy came into me, bipolar 1, and had been doing really well with maintenance. And he came in, he was euthymic. And I thought, I'm just going to use the same ketamine maintenance dose we always use, fully dissociative dose. Whoops. Yeah, and I think I've spoken about this on the podcast before, but he got manic and psychotic and came and did ECT with you. And I was so glad. Again, it's like maybe I'm not referring as many people to ECT these days, but so grateful that it's there, because if you need ECT, there's nothing else like it.
Yeah, and it seems like we're going to learn, I'm sure, and there are, in fact, I think you shared a case where, I don't think it's one of these two, who was just sworn off of ECT, or maybe not a great ECT responder, who came back and you started ketamine, and that seemed to be the magic cure, if you will, for them. So again, there's enough variability in how these things work that nothing's going to, the more tools we have in the toolbox.
With the advent of ketamine, the emergence of SNT, a supercharged version of TMS, and the medicalization of psilocybin on the horizon, the prospects for helping patients with severe and chronic depression are so much brighter. But still, some people don't respond to ketamine, nor TMS, nor ECT, and it's in these cases that we have to ask ourselves, what are we missing? Is the patient not improving because of an alcohol or cannabis dependence? Is there some kind of unresolved trauma or hormonal issues or underlying medical problems such as undiagnosed sleep apnea? Does the patient have love and work, the two core essentials for a psychologically healthy and meaningful life? This leads us back to this idea that depression is not a diagnosis. It's a syndrome. It's a final common pathway. And the job of the therapist and the psychiatrist is to help the patient unearth these often hidden pathways that are fueling the black hole of depression.